Hi friends, in this topic of general examination, today I will talk about jugular venous pressure. First is the disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only and it should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention and treatment of medical illnesses. There is no endorsement for any brand or company. Jugular venous pulse is defined as undulating top of oscillating column of blood in the right internal jugular vein that represents the pressure and volumetric changes in the right side of the heart, which changes with the various stages of cardiac cycle and respiration. Jugular venous pressure is measurement of the right atrial pressure that can provide the status of patient's intravascular volume. The JVP tracing can be obtained from inserting a central venous line into the superior vena cava or less invasively can be observed from the bedside. At the bedside, the JVP is often observed at the right side of the patient's neck. More specifically, it can be seen passing diagonally over the top of the sternocleidomastoid muscle. Why we choose a right internal jugular vein? A right-sided internal jugular vein is in direct connection at it in a straight line. Veins in the left side of the neck reach the heart by crossing the mediastinum, where they may be compressed by normal aorta, causing the left jugular venous pressure to appear elevated even when the central venous pressure and the right atrial pressure are normal. We choose right internal jugular vein because it is straight and it is in line with the right atrium. Among the internal jugular vein and the external jugular vein, we prefer the internal jugular vein because it is in straight communication with the right atrium, but the external jugular vein is not in straight communication with the right atrium. Also, the internal jugular vein has less valves, whereas external jugular vein has more valves. The various facial planes, they do not influence the internal jugular vein, but the external jugular vein gets kinked at various places by the facial planes. The internal jugular vein is less affected by the sympathetic system, whereas the sympathetic system affects the external jugular vein. Vasoconstriction secondary to hypotension in congestive cardiac failure can make extrajugular vein small and barely visible. If we have to differentiate between the carotid pulse and jugular pulse, the carotid pulse is usually better felt, whereas the jugular pulse is better seen. Carotid pulse cannot be obliterated. Jugular vein pulse can be obliterated by applying pressure at the root of neck. Carotid pulse has one positive wave, whereas jugular pulse has two positive and two negative waves. Carotid pulse is medially seen, jugular pulse is laterally seen. Carotid pulse is seen in the lower part, whereas jugular pulse is seen in the upper part. Carotid pulse has definite upper level. It doesn't have definite upper level, whereas the jugular pressure have or jugular pulse have definite upper level. Carotid pulse is has expansile impulse, that is outward, whereas jugular venous or jugular pulse has retractile impulse, that is inward. Carotid pulse does not change with the position, whereas jugular pulse changes with the position. Carotid pulse does not change with respiration, whereas jugular venous pulse that changes with the respiration. Carotid pulse does not change with the abdominal compression. However, the jugular pulse changes with the abdominal compression. Coming to JVP measurements, whenever we have to measure the JVP, the patient should be comfortably lying in semi-reclined position, that is at 45 degree. Head should be raised to 45 degree. The patient's neck should be slightly turned towards the left side. We have to shine the torch light onto the neck tangentially from the left side. Observe the pulsation between the two heads of sternocleidomastoid. Trace the pulsation and locate the upper level with two scales. We have to trace the pulsation and locate the upper level. Then we have to take two scales. Place one scale at upper level of the JVP parallel to the ground, and then we have to place the second scale at the level of sternal angle perpendicular to the first scale. We have to measure the vertical height of the second scale, and this is expressed as centimeter of water above the sternal angle. Whatever height we get, we have to add 5 centimeter to the value to determine the right atrial pressure. Usually it is measured in centimeter of water. However, we can convert this centimeter of water into millimeter of mercury. The conversion formula is 1.36 centimeter of water or blood is equal to 1 mm of mercury. The various causes of raised JVP, they can be categorized as when there are engorged and pulsatile neck veins, and second is when neck veins are engorged but they are non-pulsatile. Among the engorged and pulsatile neck veins, we have cardiac causes and non-cardiac causes. The cardiac causes are right-sided heart failure, congestive cardiac failure, chronic constrictive pericarditis, cardiac tamponade, complete heart block, restrictive cardiomyopathy, SVC obstruction, and tricuspid stenosis. The non-cardiac causes are pulmonary thromboembolism, pulmonary hypertension, acute nephritis, pregnancy, fluid overload states. Among the engorged and non-pulsatile causes of raised JVP are the superior mediastinal syndrome, Valsalva maneuver, and chronic constrictive pericarditis in advanced stage. The components or waveform which are seen in JVP are A wave, X wave as initial X descent, C wave, X dash wave, that is X descent following the C wave, V wave, Y wave, and at times H waves. The A waves are due to atrial contraction or atrial systole. X wave or initial X descent is represented by atrial relaxation and the resulting rapid atrial filling. C wave is due to the contraction of the right ventricle, that is ventricular systole, causing the tricuspid valve to bulge towards the right atrium during the right ventricular isovolumetric contraction. X dash wave, that is X descent following the C wave, it is due to downward movement of the floor of the right atrium while the right ventricle contracts. This is called descent of the base, or it is the result of the right ventricle pulling the tricuspid valve downward during the ventricular systole. The V wave is because of atrial filling during the ventricular systole, and it represents venous filling when the tricuspid valve is closed and venous pressure increases from the venous return. The Y wave is because of right atrial emptying during the ventricular diastole, and finally, as the tricuspid valve opens and the blood in the right atrium empties into the right ventricle during the ventricular diastole, we get Y wave. The H wave, also called Hirschfelder wave, it is seen in diastasis. In this diagram, we can see the various waveforms of the JVP, that is A initial X descent, C wave, X descent after the C wave, V wave, and Y descent. This picture also depicts the various waveforms which are seen. I have already discussed that A wave is because of atrial contraction, initial X descent is because of atrial relaxation. C wave is because of ventricular contraction. X dash descent is because of extra space, and V wave is because of atrial volume when the atrial volume increases, and Y descent is because of atrial emptying. If we see the JVP in relation to heart sound and ECG, as we know that JVP has A wave, positive A wave and C waves, and V wave, X and X dash descent and Y descent. And these initial X and C waves and X descent in later stages, that all falls under S1 and S2, and A wave is before S1, and V wave and Y descent are seen after S2. Coming to various abnormalities of the JVP, large or giant A waves, they are seen initially when there are no A waves in the JVP or absent A waves, this condition is seen in atrial fibrillation. Large or giant A waves, they are seen in tricuspid stenosis, tricuspid atresia, right atrial myxoma, right ventricular infarct, right ventricular myocardiopathy, pulmonary hypertension, pulmonary stenosis, and pulmonary embolism. Aortic stenosis, hypertrophic cardiomyopathy. We also see large or giant A waves, and this effect is seen in this effect is called Bernheim effect. Bernheim effect is when the left-sided disease causes prominent A wave. For example, in severe LVH with septal thickening, this interferes with the right ventricular filling, resulting in prominent A wave. Canon A waves are seen in junctional rhythm, ventricular tachycardia, and in these Canon A waves are regular. Irregular Canon waves are seen in complete heart block, AV dissociation, ventricular ectopics, ventricular tachycardia, and V pacing. Diminished V waves or prominent V waves. Diminished V waves are seen in hypovolemia, and prominent V waves are seen in tricuspid regurgitation, atrial septal defect, ventricular septal defect, and there is one defect called Gerbody defect. It is the abnormal shunting between the left ventricle and the right atrium due to either a congenital defect or prior cardiac insult. The prominent V waves are also seen in congestive heart failure, atrial fibrillation, and cor pulmonale. In tricuspid regurgitation, due to absent X and prominent V wave, they merge with the C wave, and it results in large positive systolic and regurgitant wave. We call it as a CV wave. It is followed by a rapid Y descent, and this may cause subtle motion of the earlobe with each heartbeat, and we call it as a Lenzi sign. This is Lenzi sign is subtle motion of the earlobe with each heartbeat seen in tricuspid regurgitation. X descent versus Y descent. The X descent is because of systolic collapse. It is absent in tricuspid regurgitation, and it is very prominent in tamponade, atrial septal defect, constrictive pericarditis. The Y descent, that is diastolic collapse. The slow descent is seen in tamponade, tricuspid stenosis, and right atrial myxoma. A rapid descent is because of constrictive pericarditis, severe tricuspid regurgitation, and severe right ventricular failure. In the patients with constrictive pericarditis or cardiac tamponade, we have a mnemonic to differentiate them. Mnemonic is PATEX, that is pay prominent Y and X. They can be remembered with this mnemonic. For example, in constrictive pericarditis, we get Y wave more prominent than X waves, and similarly cardiac tamponade, the X waves are more prominent and Y wave are usually absent. Tricuspid regurgitation, the X waves are absent but Y waves are prominent. So constrictive pericarditis, just remember P and uh, add and we pay tax. Constrictive pericarditis, pay tax means PAYP pericarditis, Y is more prominent, and tamponade tax means T for tamponade and X is more prominent, tax. Just remember pay tax. The other sites where we can estimate JVP are Gartner method. Normally the superficial veins of the dorsum of hand, they collapse when raised above the sternal angle. Persistent prominence is suggestive of raised central venous pressure. The anthem sign is when the same is tested by asking the patient to make a fist and raise the arm like an anthem pledge. May sign is visible engorged veins on the under surface of the tongue in sitting posture. Coming to abdominojugular reflex, uh, abdominojugular reflex of run dot. Previously it was known as hepatojugular reflex. In this, the patient is placed in 45-degree semi-recumbent position and firm consistent abdominal pressure about 40 mm of mercury is applied and preferably over the right hypochondrium. An inflated BP cuff may be used. Historically, the pressure was applied for 15 seconds. However, the recent studies they suggest that it should be applied for at least 10 seconds only. The normal response is transient rise of 4 centimeter of about 4 to 5 cardiac cycle, means transient rise of this JVP by 4 centimeter for every 5 seconds. Sustained response or positive response is earliest signs of ristic. If we get positive response or sustained response, it is suggestive of, or it is the earliest sign of right heart failure, and it can be seen in tricuspid regurgitation. Absent response or negative response means it is suggestive that there is obstruction or thrombosis of the inferior vena cava or hepatic vein as seen in Budd-Chiari syndrome. Other important signs in JVP are Frederick sign. It describes as a rapid fall and rise in JVP. It occurs when stiff ventricles are unable to accommodate the rapid ventricular filling that should follow opening of the tricuspid valve in the presence of elevated arterial pressure. The square root sign of JVP is dip and plateau pattern of JVP seen in constrictive pericarditis. Kussmaul sign of JVP is normally when the patient inspires, there is fall in the height of the JVP due to increased negative intrathoracic pressure. And this Kussmaul sign is the paradoxical elevation of the JVP during inspiration, and it is seen in constrictive pericarditis, severe heart failure, right ventricular infarction, or restrictive cardiomyopathy. At times we get M pattern in JVP. For example, in constrictive pericarditis, due to prominent X and Y waves, we get M pattern. And in patient with ASD, due to prominent A and V wave, we also get M pattern. The raised jugular venous pressure with shock is seen in congestive heart failure, cardiac tamponade, right ventricular infarction, tension pneumothorax, and massive pulmonary embolism. Jonathan Swift has said the best doctor in the world are Dr. Diet, Dr. Quiet, and Dr. Merriman. With this, I conclude my today's topic. Thank you. Keep learning.